to touch on very, very briefly what Nadine has already gone through. So Whipple, initially described by Karish in Germany, which includes resection of distal stomach, head of the pancreas, bile duct, and the duodenum. This was modified by Alan Oldfather Whipple in the US in 1935. Initially a two-stage procedure, modified to a one-stage procedure. He performed 37 in his lifetime. Then there was the advent of the pylorus-preserving pancreatic duodenectomy, described by Wilson in 1942 and taken on by Traverso and Longmire in 1978. And as the title suggests, preservation of the pylorus of the stomach, with the thinking that you maintain good GI function, there's reduced dumping syndrome, and there's a decreased risk of bile reflux. And then you have operations on the pancreas, and as Nadine has extensively covered, distal, central, and total pancreatectomy, amongst others. So on the top right of the screen here, we've got Mr. Whipple, and here you can see what's resected. So in A, you've got sort of distal stomach here, bile duct, head of the pancreas where the lesion is here, and the duodenum. In B, you can see what's joined to what, so pancreas to jejunum, bile duct to jejunum, and stomach to jejunum there. Okay, and here are the two different configurations that you can end up with, and it's surgeon preference as to whether you have an end-to-end pancreatic jejunostomy or an end-to-side. In Guildford, we go end-to-side. The Traverso and Longmire with their wives, and here you can see the preservation of the pylorus in this type of surgery, and again the end-to-side or the side-to-side anastomy, so the pancreatic jejunostomy. This is just a quick slide looking at pancreatic resections. So here we can see distal pancreatectomy with staple line here at the neck of the pancreas. Over here, these two images cover a central pancreatectomy, the lesion here, and this one down here looks at the total pancreatectomy as well. And this is what the configuration looks like after that procedure is done. So I'm going to talk mainly about local practice. I assume your sort of majority of you will be local GPs and will be dealing with a patient population around here. Standard procedure that we tend to use for the reasons mentioned previously is the pylorus preserving pancreatic duodenectomy. To look at some of the data, we performed 77 resections between April 2013 and 2014. And as Nadine mentioned as well, there's an enhanced recovery program here. So everything is carefully thought out before the patients come to theatre. They have a document which follows them through from day one of surgery post-operatively, and we follow that as much as we can to the book to make sure that we're doing everything that we can for them. Importantly, and probably the most important factor, is that they're looked after by a multidisciplinary team, and that includes intensive care consultants. They get discharged and step down to intensive care afterwards, hepatobiliary consultants, dietitians, physiotherapists, nurse specialists, all of the team working to get them better after such a major operation. Morbidity rate here is relatively low, 28.5%. Again, as we mentioned, as high as 40%, sometimes even higher in the literature. And in that period of time between 2013 and 14, we had 2 incidences of hemorrhage, 7 incidents of pancreatic leak, 3 instances of gastric dysfunction, and there were 10 other complications, including wound infection and intra-abdominal collection. And the mortality rate can be as high as 5%, but in that period of time for us it was less than 1.5. So I'm going to talk about the following post-operative complications that patients might struggle with after the operation: delayed gastric emptying, bile leak, fistula, and post-operative hemorrhage. So delayed gastric emptying will manifest patients vomiting. They won't be tolerating oral diet, be that sloppy or liquid diet. And what they'll have when they get discharged from hospital is nutritional supplements. And they may need an adjusted diet, so they may need sloppy diet when they go home. They may not be on a normal diet as they were before the operation. Talking about bile leak then, tends to be from hepatic jejunostomy. As I mentioned, there weren't any incidences in the year that we sort of looked at, but in the literature, the general incidence is between 1 to 2%. And we tend to notice these by presence of bile in drains. We manage these conservatively. We leave drains in situ and generally settle down with conservative management. But again, with the enhanced recovery program, patients will go home with drains in situ, so they may sort of be recovering still but be at home, so it's important to be aware of this. Pancreatic fistula, and this is diagnosed when we send off a drain amylase, which comes back being 3 times higher than the serum amylase to the lab. Incidence of this is about 10 to 20%, and as you can see from our figures, ours is less than that as well. This is the most significant cause of morbidity in this subset of patients. It can cause intra-abdominal collections, abscesses, and importantly can lead to formation of arterial pseudoaneurysm. Pancreatic enzymes such as tryptophan and elastase degrading the arterial walls, which can give rise to that. And what we do routinely in the enhanced recovery program is we check 72 hours post-operatively the drain amylase levels. Risk factors for pancreatic fistula is a soft gland, as you can imagine, and a small duct. Again, we try and manage these conservatively with drainage, and many patients will go home with drains in situ until these settle down. There should be some images there. Shall I get the... Okay. Sorry, I had some CT images of pseudoaneurysms and... fine, so moving on to hemorrhage, obviously is a life-threatening complication. And secondary bleeds due to pseudoaneurysm tend to occur up to 10 days after the operation, but it's really important to be aware that it can occur up to a month after people have had operations, so they'll be in the community at high risk. May present as coffee ground, hematemesis, melena, or there may be a flash of blood in a drain, which is a new finding. There are images here, sorry. So here you can see this little swelling here. So this is a pseudoaneurysm, probably of the gastroduodenal artery, which is the main offender really in this type of thing. And this is just the results of a study published in 2010, and it highlights the incidence of bleeding in the post-operative day. So you can see the majority happen within the first couple of weeks of the operation, but it's important to be mindful of there is a subset of patients up to a month after the operation who are prone or at risk of having one of these bleeds. We have an excellent interventional radiology department at Guildford, which is available 24 hours a day, 7 days a week. And if a patient does have bleeding, we try and manage it conservatively, either through embolization or exclusion stenting. If these initial measures fail, then the patient needs to undergo a laparotomy. And here you can see 2 images. These are coils which are inserted to stop bleeding. I'm not sure if it shows up very well there, but this is a stent which the guide wire is going through. So things to be worried about in the community. Patients post-Whipples developing new onset temperatures, fevers, vomiting, new onset of abdominal pain or increasing abdominal pain, distension, reports of coffee ground vomiting, reports of melena, any suggestion that there may be blood in the drain. Those are all concerning signs. I think the key message that I would say to you is to have a high index of suspicion in any of these cases, and it's really important to be aware that you can always access, at least you should always be able to access the hepatobiliary team, and I would suggest that the first port of call would be either the registrars who are available through the switchboard 90% of the time, or the CNSs. They can give advice over the phone, they can arrange urgent admission for these patients if it's necessary. We have something called Room 5 on Copthorne Ward, which we can book patients to at short notice to review them, drains, etc. if there are any problems with those. I understand they can be problematic in the community. And also there's also access to Mary and Lois and the team of dietitians here. So I would always ask for help if there's any concern. And if you do want to transfer them into the hospital, I would always contact the HPV team as well as the on-call surgical registrar, because they may not sort of appreciate necessarily exactly what's going on. I'm going to hand you over now to Mr. Menezes.